Cravioto will give us an overview first of all, and then we'll open it to questions. So over to you, Alejandro.
Thank you very much. I hope you can hear me.
Very well.
Okay. Good morning from Geneva, everyone. Good afternoon or good evening, wherever you are. We had a very interesting meeting yesterday in which we reviewed a huge amount of information, and these will be the main outcomes. First of all, we would like to say that SAGE is continually reviewing data available regarding boosters. And let me just make a clear statement of what we mean by a booster dose. Booster doses are administered to people who have been vaccinated with what we call a primary vaccination series. Currently, that means 1 or 2 doses of all the vaccines that have received an EUL approval by WHO. When we time the immunity and clinical protection of these vaccines has fallen below a rate deemed sufficient in the population, then we suggest the use of a booster dose to restore the vaccine effectiveness from what seems to be now no longer sufficient. I hope that makes it clear of where we are and what we're doing. So there is emerging data that shows a decline in vaccine effectiveness against SARS-CoV-2 infection and COVID-19, with a more significant decline in older adults. This evidence is largely based on observational studies with variation in the results from different platforms and, of course, different population groups. But the current data shows that vaccines have a robust level of protection against severe forms of disease for at least 6 months, although some waning has been observed against severe disease, especially in older adults or those with underlying medical conditions. The SAGE roadmap on the prioritization of vaccine use in limited supply, published the 16th of July of 2021, stipulates that the primary public health goal of the acute stage of the pandemic is to reduce deaths and severe disease due to COVID-19 and to protect the health systems. In this context of ongoing global supply constraints, broad-based administration of booster doses risks exacerbating inequities in vaccine access. The vast majority of current infections are the results of infections in unvaccinated people who we believe should be vaccinated instead of giving further doses to those that have already received the full immune system, the first vaccination program. This statement was updated on the 4th of October of 2021. So in this sense, we are clear that for the time being, we continue to support, 1, the need for equity in the distribution allocation of vaccines, and 2, the use of third doses only on those that we have previously recommended, those that have received inactivated vaccines and those that are immunocompromised, which are the 2 groups that we feel should be protected further by a third dose of the primary process. In relation to the other 2 issues that we discussed, the first one is related to our recommendations about the heterologous use of vaccines. This has been talked a lot about, of whether we can mix and match vaccines for the primary or use of these products. So WHO supports a flexible approach to homologous or a single platform versus a heterologous mix and match schedules. We still believe that the best approach is to use the same vaccine for the 2 primary doses. Now, in order to achieve a primary series coverage in priority groups for national immunization programs that have issues related to their supply, then we can actually use a different vaccine for the second dose if that is the one available. The interchangeability of these vaccine platforms would allow flexibility within immunization programs, for example, in the face of constrained or unpredictable supply. Now, for countries that decide to do this, we would recommend two things. One is if the initial dose that you have received is from an inactivated vaccine, then a second dose can be used with an mRNA or a vector-based vaccine. That means, for example, using a Pfizer or an AstraZeneca vaccine or a Johnson & Johnson or a Moderna vaccine for the second dose. Depending on the availability, when we have used mRNA vaccines as the first dose, the subsequent one can be one of the vector-based vaccines and vice versa. For the vector-based vaccines, we can use an mRNA vaccine. What we continue to review evidence of this heterologous use, we will then make further recommendations about what becomes available. The second thing that we recommended as part of our discussions are interim recommendation updates for the Janssen or the Johnson & Johnson vaccine. Now here, the initial data that we had when we reviewed the vaccine the first time was to use a single dose for a primary series. And that continues to be effective, and we continue to recommend that. However, data that has been supplied by the company of further studies, clinical trials that they have conducted using 2 doses instead of 1, have clearly shown the benefit of having a further vaccination in this group. Will those that receive 2 doses be fully vaccinated? Yes, 2 doses will be continued to be used as a fully vaccinated scheme in those that have received the 2 doses initially. Although for the purposes of the full vaccination schemes currently, 1 dose is still sufficient to be considered as such. Let me go back again. This is idea that 1 dose is sufficient to be considered of the Johnson & Johnson vaccine to be fully immunized, but 2 doses can make a difference in those that need to receive a further support. The conditions for the single dose are useful in places where you have a limited supply, or places that are hard to reach populations. For example, if you need to go to a place and vaccinate the whole population and you cannot come back soon enough to give a second dose, then a single dose would be far an advantage. In the sense of the countries that decide to give a second dose, this can be given from 2 to 6 months after the first one. And in a sense, we still feel that lengthening the interval between these 2 doses is the best way to go. So the closer you can get to 6 months, especially in those that are over 65 years of age, the better response you might have to the second dose. In this case, and following the recommendation we talked about previously of using heterologous strains, a second dose for the Johnson & Johnson vaccine can also be one of the other ones that we have been using, which could be an mRNA or a vector-based vaccine as a second dose, which would have a similar effect to using the homologous strains twice. I think that I would leave it there and ask Joachim or Kate if they would like to add something. Thank you very much, Margaret. Over.
Thank you very much, Professor Alejandro Cravioto. I will ask Joachim or Kate, have you got any further remarks you would like to make, or would you like us to go straight to the Q&A? And while I'm saying that, I can see there's one hand already up for the Q&A, but could everybody else get their hands up now so that I can make sure I ask you, give everybody plenty of time. Joachim, would you like, or Kate, would you like to make an additional remark?
Not from my side. This was a very comprehensive summary, so good for me.
Yeah, I think we should just go to the Q&A.
Perfect. Okay, so the first question goes to Christian Ulrich of DPA. Christian, unmute yourself and ask your question.
Thank you, Margaret, and thank you, Alessandro. My question is still on the booster. The reality in the country that I come from or where I live is that governments very strongly recommend a booster for basically everyone. And I wonder whether you were also looking in this mix and match when it comes to boosters, or are you just not touching that subject because you would not recommend a booster for the general population at this point? Thank you.
I can say a few words.
Apologies, I unmuted it. Oh, Joachim, go ahead, please.
Yeah, in relation to, I mean, we obviously know that countries are widely boostering, and with different ambitions, we still emphasize the importance of the prevention of severe disease and death. We acknowledge that many countries are boostering from a different perspective, for instance, to reduce transmission. We need to say that on that side we have much less data. So this is obviously an ongoing review the WHO is conducting, as Dr. Cravioto pointed out. In relation to the heterologous schedules, we will be bringing out this policy in form of what we call good practice statement probably next week, and you will see in there there's a very comprehensive review of all the available data, immunogenicity and effectiveness data of the different combinations of vaccine was done, and this includes booster doses. So the statement that we will bring out is also covering the issue of booster doses in relation to the suitability and in relation to the potentially improved performance of certain combinations. So this is covered. Because obviously we understand that this is going on, we also have select recommendation of additional doses as already pointed out by Dr. Cravioto. So we are not just looking in relation to the heterologous schedules to the primary immunization, but we also include the subsequent doses that may be booster doses.
Thank you very much, Joachim. Unless Kate wants to add anything, I will go to the next question. Yeah, the next question's from Gabriela Sotomayor. Gabriela, please unmute yourself and ask your question.
Thank you very much, Margaret. Well, good morning, and thank you very much for this briefing, and especially Dr. Cravioto. I don't know if he's in Mexico, but thank you so much. So my questions are regarding Mexico. In Mexico, there are millions of people that were vaccinated with Sinopharm, Sinovac, and also with CanSino. And now the government just announced that they will begin to put the booster dose with AstraZeneca. Is that okay in your view? Is it okay? Is it correct? What are your advice for Mexican government? Especially there is a lot of people very, very nervous about this CanSino vaccine. And then my second question, do you recommend booster doses for health personnel, the people working at hospitals? Do you recommend that for them? Thank you.
Thank you for your question, Gabriela. I'm actually in Geneva today.
Okay.
But I would like to make it clear that the advisory group that the Mexican government has set up, the independent advisory group, has been also looking at these issues. And we have recommended long before, and the government has taken our advice to give a booster dose to those that have received a single dose of CanSino, and also to the elderly that are over 60 years of age that have received any of the inactivated vaccines. And the government is already doing that with the supply that they have, apparently, which is of the AstraZeneca vaccine. I think, as I had said before, if you're using a heterologous strain after an inactivated vaccine or a vector-based vaccine, then you can use either another vector-based vaccine, which would be the case of CanSino and AstraZeneca, or in the case of the Sinovac and the AstraZeneca. So yes, this would comply with the recommendations that SAGE is making, and I think the government is now going in Mexico to follow up this process. I don't know how they have decided to do the boosting. They have started apparently with the people over 60 years of age, But I am sure that one of the things that the group has recommended is also the consideration that the health personnel has to be protected fully. So probably they will be in line to receive the next extra doses once the government decides that that's the second group that they will be looking into. Over.
Thanks very much, Alejandro. The next question is from Simone McCarthy, South China Morning Post. So Simone, could you unmute yourself, ask your question, and let us know who it's directed to as well.
Thank you so much. I appreciate the invite to the briefing today. I am going to ask a question which is, I understand, not specifically on the agenda for the last SAGE meeting, but I'm sure that many of us have Omicron on our minds, especially in the wake of the neutralization studies that have come out in recent, I guess, just over the past 24 hours. And so I just wanted to ask, as far as SAGE is concerned, whether or not there has been any discussion of the findings in the reduction of neutralization as compared with other strains, and also just as for SAGE regarding whether or not there will be a need for boosters, especially in relation to what happens with Omicron, if there's any conversation about having, expediting when the next emergency session is in order to specifically look at the emerging data as we see it come out in the coming days and weeks. And then I guess I'm also just, if I could just tack this on, I'm just wondering if the recommendations about boosters as they currently stand are very much related to the supply side. And if there wasn't those supply constraints globally, whether the recommendations may actually be different. So thank you so much, and sorry to ask a couple of things there.
All good questions, and Dr. Kate O'Brien will answer your excellent questions.
Thanks so much. I'll try to go through each of them. The first is quite straightforward to address. SAGE met on December 7th, and the data that you're referring to on the neutralization were coming out after SAGE had met. So SAGE is aware of the data, the early studies that have come out. I think we all recognize that those studies of neutralization on the Pfizer vaccine post-vaccination sera are early days, small numbers. They are laboratory-based neutralization assays. And as I think everybody is aware, we don't have a specific correlate where you can go from neutralization to a sort of an estimate of what the vaccine performance would be. They are important studies, and many more are going to come out, some by the end of this week, some into next week. What's really important is that those data are across not just one vaccine, but across a number of different vaccines. And what we're really looking for are the clinical data, the performance of the vaccine in people against clinical disease or infection. So although the neutralization data give us a sort of direction of travel, it doesn't answer the specific question that SAGE will have, and frankly, that we all have, which is the performance of the vaccines against clinical disease and against infection. So that's really the critical piece of data. From a sort of process perspective, SAGE will convene for any emergency session when it's the right time, when the evidence is available for SAGE to weigh in from the policy perspective. We do have a set of expert committees that are set up to address a variety of issues around variants of concern. And that includes the committee that is looking at whether or not there needs to be any change in the composition of the vaccine. And SAGE then takes over from there after advice on any change in composition. So SAGE will absolutely be keeping up to date on the evidence as it emerges, and will be briefed on that evidence as it comes out. Then on the issue of boosters and supply, so certainly for Omicron, one of the strategies may be that additional doses have benefit to provide added protection against Omicron. Again, very early days, and we will follow the data and provide recommendations based on what the evidence looks like. But that first study looking at 3 doses versus 2 doses is of interest. And yet There are different methods being used across studies, and we also need data on additional vaccines. And with respect to the supply issue, what we're really looking at is that severe end of the disease spectrum for the whether or not boosters are needed to optimize the protection against that severe end of the disease spectrum. And as Alejandro described to you, the evidence that SAGE has reviewed, which is an exhaustive set of evidence, does show some minor, modest reductions in protection, although there is variability in the data study by study at that severe end of the disease spectrum, and more reduction on the mild end of the disease spectrum. So as the recommendations are developed on the approach to boosters, each of these is part of the considerations. And certainly when we are referring to the prioritization, that prioritization is in the context of constrained supply. A prioritization is much less relevant when there isn't a supply constraint. So that these two things really go hand in hand. And of course, any supply constraint has to be understood and described about what geography we're talking about, if it's a global supply constraint or a country-specific supply constraint. So that's what the prioritization roadmap does. And we will be looking at how the issue of booster doses may relate to that prioritization roadmap.
Thank you very much, Dr. O'Brien. The next question goes to Isabel Sacco. Isabel, can you unmute yourself and ask your question?
Good morning. Thank you. I would like a general comment on the situation that we are seeing a lot of us in Europe and North America, especially where the vaccination started first. A lot of people in these regions are being infected with COVID-19, despite the fact that they are vaccinated, completely vaccinated. And we are seeing this situation multiplying in the last weeks. So I would like to know if, and of course, this put a lot of doubts on the performance of vaccines, and these give arguments also for some anti-vax groups. So what is your conclusion? What are you reviewing this data? What could you say about how long the vaccines that we are using now last and give immunity? And secondly, if you can say something on vaccines for children under 12. If you are reviewing also data, and if you think that you will maybe taking any decision or recommendation mostly on this age group. Thank you.
Thank you very much, Isabel. And Dr. O'Brien will answer your question.
Thanks. I'm just getting off mute. Perhaps I'll address the question, the part of your question that is about breakthrough infections and about duration of immunity and duration of protection. And I'll pass over to Joachim to address what SAGE is doing on vaccination for children. I'm not sure if that's adolescents and children you're referring to, or what we would call children younger than 12 years of age. So first, on the issue of breakthrough infections, super important to remember that as vaccination coverage increases, as more and more people become vaccinated, of the cases that occur, eventually there will be a larger proportion of the cases will be people who are vaccinated than unvaccinated. So it's not surprising that as vaccination coverage increases, just by virtue of the fact that there frankly are more people who are vaccinated, you will see more numbers of breakthrough events among people who are vaccinated. That does not mean that the vaccine is not working. It simply means that a greater and greater number of people have actually been vaccinated. And so there's more, there's a greater population in which those breakthrough cases would occur. What is super clear from the data is that the vast majority, the greatest risk is among people who are unvaccinated. We have a two-track pandemic now. For those people who are unvaccinated, the vast majority of hospitalizations and deaths, and depending on what data set you look at, upwards of 80–90% of those people are unvaccinated people. So really important to not misinterpret what it means that there are breakthrough infections. They will increase in number as the number of people who are vaccinated also increases. That does not mean that the vaccines are not performing well or not holding up. On the duration of protection, we've reviewed the data. Most of the data are up through 6 months of duration. There are starting to be data that are coming out that are looking at longer periods of protection. However, some of those are in the setting also where a decision was made to go ahead and get booster doses. And so we've got some complex data now that following 6 months, it's a mixture of people who have had 2 doses and 1 dose. But I'll just repeat again that on the review of the data, the protection against severe disease, hospitalization, and death holds up very well through 6 months following the last dose of vaccine, with some minor or modest reduction in protection. For that more mild end of the disease spectrum, infection or any clinical disease, regardless of whether it's mild, moderate, or severe, what the data show is that there is more of a reduction in the protection that was initially found after doses were given. So this should not be interpreted to mean that the vaccines are not working. They are working. They're working very well. And of course, the issue about where the priority is for sustaining that highest level of protection against severe disease, that's the end where we see only this minor or modest reduction in protection. So I'll turn over to, just on the duration of protection, we absolutely expect that the data will continue to flow out about how long people are protected by 2 doses. And of course, data are emerging on what the performance is after having received a 3rd dose. I'll turn it over to Joachim on the question of vaccinations in children and SAGE's review of those data.
Yeah, thanks very much. So we have, first of all, as a point of reference, we have released 2 weeks ago what we call an interim statement on the vaccination of children and adolescents against COVID-19. It's I think, a very good state-of-the-art summary in terms of the findings and in relation to our current position. I mean, first of all, when we talk about this group, we normally separate children below 12 years of age and then adolescents above to 17 years of age. I think when you look into the question, you need to consider a couple of issues. The first is obviously, and the most important, is the burden of disease. And we know that the disease tends to be much milder in young people, even though there are, of course, rare complications like the multi-system inflammatory syndrome. We have reports of long COVID, even though there are not that many. But overall, it is clear understanding that the burden of disease, and it's clearly documented, is significantly lower and normally the disease is mild in children and adolescents. The second question is around the role of this population in transmission. And I think this is a very important one, in particularly if you think about, so to say, a further rollout and an increasing coverage of populations. And we know that adolescents transmit pretty much as adults. Children may be transmitting somewhat less. We have then a very important consideration, I think, when it comes to the vaccination of children and adolescents, and this is not related to the disease, but it's related to participation in society and the socioeconomic component. That's something that we are taking extremely seriously, and we have actually clearly outlined in a number of documents, including our roadmap, that children and adolescents should not be prevented from really participating in social life, and in particularly in education in the context of COVID. And the most important strategy is here actually to protect the adults that are and have the adults vaccinated that are in close interaction with children and adolescents. So that's a very important strategy. We know there is a number of vaccines that have now been authorized for children and adolescents, and we are also in the emergency use listing process reviewing the data, and we will be also in due course reviewing the data at SAGE, and we know that on balance the data show that the vaccines are safe and efficacious. We currently stay with our position based on global equity considerations, based on the successive rollout and increased coverage with COVID vaccines, that children and adolescents represent a lower priority group, with the exception of certain children and adolescents that have morbidities that put them at very high risk of severe disease. That is clear, and we have this already in our current recommendations. Continue to monitor how things evolve, but in the context of our overall prioritization that we have, children and adolescents are not part of a priority group, but they may become, and they will become, very important when really the transmission reduction goals will become very prominent in the future.
Thank you very much, Joachim. The next question, it belongs to Jamie Keaton. Jamie, unmute yourself and ask your question.
Good morning. Thank you, Margaret, and thank you everyone for holding this. WHO has spoken often to the public, not just healthcare policymakers or companies or scientists, about what they can do to advise things like mask wearing, physical distancing, or airing out rooms. It seems to me that the call to fight vaccine inequity is by getting out doses to countries in need is mainly aimed at governments and pharmaceutical manufacturers. I'd like to request for a moment that you speak as if you're speaking to a person on the street. Given your emphasis on getting first doses to people around the world, what is your advice to individuals, particularly in wealthier countries with excess vaccines? Should they forego boosters in the hope that the doses might get shipped to needier countries as a moral stance and a show of solidarity? Or should they press their governments, which are in some cases providing conflicting signals to people, as Christiana mentioned? Some are urging or enticing people to get boosters compared to what WHO says. And to just take it a step further, take France, where some WHO staffers surely live. It's maintaining its COVID pass valid contingent on having boosters for some broad age groups. Is WHO recommending that its own staff not get boosters, whether they are frontline healthcare workers or just administrative staff? And finally, what do you say to those who note that the long-term goal of getting first doses to people is laudable over the long term around the world? There have been distribution and expired doses problems, and above all, most deaths by far are still in rich countries with lots of vaccines. Thank you so much.
Thank you, Jamie. Dr. Kate O'Brien will answer that.
Thank you, Jamie. That was a long statement, and I think there were some questions in there. I was trying to pull them out, so I'll do the best I can. If I've missed one of your questions, maybe we can come back after in another round. We're super clear, Jamie, and all. Our calls for vaccine equity are calls for the evidence that shows that we are not going to get out of this unless we actually have true vaccine equity and distribution of vaccines in a timely fashion to every country around the world. And I think this latest example of Omicron sort of puts a fine point on that. These are calls to the stakeholders who can actually take action on those things. Those are not individuals in countries. We've been very clear that individuals in countries should follow the policy of their country. And this is not a message to individuals. Individuals certainly, if they have a personal view, on a, as you said, on a, taking an ethical stance or moral stance, or from a data stance. But an individual in a country, their dose is not going to get shipped to another country because they don't take the dose. We are supporting every country through the SAGE policies to help support every country make their own policies of how they want to proceed. Now, so I think we're clear on that. What we are also clear on is it is the manufacturers and it is country governments, not individuals, who are making decisions that could influence the equitable distribution of vaccines to other countries. So those are the stakeholders who make those decisions and who we believe are the ones who need to act based on the data, based on the evidence, based on the calls for equity, for all the reasons that we've pointed out many, many times to the world. You asked a question that I would like to address about distribution of vaccines and wasted doses. And I want to be clear that from COVAX, the proportion of the doses that have been wasted relative to the proportion that have been shipped to countries is smaller than in many high-income countries. Every country has some element of wastage of vaccines. And so this is not, and I want to be really clear on this, this is not a problem that is disproportionate nor unique to countries by income strata. And in fact, at the present time, the data go in the other direction, which according to our analyses, there is actually a lower proportion of wastage for COVAX doses than there are in a number of high-income countries. In addition to that, the quality of the supply that is being provided, and I don't mean the quality of the vaccines themselves, I mean of the supply itself. In other words, the shelf life of the vaccines, the timing of when those vaccines are made available for shipment, and the amount of notice that a country has that a shipment is coming, those are directly related to whether countries can adequately use those vaccines. And especially for the donations, which are a critical part of getting doses to countries. The quality of those donations has not been universally a quality that makes any country, whether it's a high-income country, of any income strata, a low-income country, it's extremely difficult for a program to use doses that come with short shelf life. And that has been the major problem, along with the lack of foresight into when doses are coming. So I do want to be clear about the wastage issue and where the responsibility and where the root cause of that sits. I think those were your main questions, which was about individuals, about expired doses, and about distribution. Thanks.
Thank you very much, Dr. O'Brien. The next question goes to Apurva Mandavili from New York Times. Apurva, please unmute yourself and ask your question.
Thank you very much. I have two questions. One is a tiny practical one, which is, you said that people who got inactivated vaccines and the immunocompromised, you do recommend extra doses for, and are you including 65 plus in that immunocompromised category? And then really the bigger question is, you said that you would revisit this decision for, when it is the right time. And I wanted to ask, what is that right time for Omicron? How much evidence will you need? And you said clinical data, but obviously that takes time. Are you looking for population level data? What is your bar for deciding to revisit this? And then finally, I wanted to say that the timing is a bit surprising that you're coming out with these recommendations now when everybody's talking about Omicron and whether vaccines work against Omicron. So do you worry about the risk of seeming out of step with what everybody's concerned about right now, and also possibly confusion if you have to change what you're saying in just a few weeks? That's it.
Thank you very much for those questions. I'll start with Professor Alejandro, and others may join in.
Thank you for your questions. First of all, yes, we have recommended before that people who have received inactivated vaccines should receive a third dose as a primary vaccination. We have studied the evidence in SAGE and we have come up with these recommendations. We have also included in this group the people who are immunocompromised. And as you well say, those of us who are over 60 have an immune system that is not as robust as when we were 25 or 30. So we have also included in that group people who are over 65 years of age. And in many countries that have used these inactivated vaccines, this third dose is already in practice, including where these vaccines have been produced, which is China. So in that sense, we are moving on. In the case of being out of step, I think in SAGE we have been clear that this is a moving target and that we have been constructing a plane while it is still flying. And if you go back in our history, we actually started looking at this prioritization map long before there were any vaccines available. So I think we have been quite in step with what is happening, taking into account basically what is real information and evidence for us to make our decisions. I would leave it to Dr. O'Brien to talk about the new variant, but I would remind everybody that between Delta and Omicron in the Greek alphabet, we have 10 letters. 2 of those have not been used for variants, Nu and He, for different reasons, but we still have other 8 variants that have come up. They have been studied, they have been assessed, and they have not been considered irrelevant in any way, but they have not progressed in that sense. I think in the case of Omicron, we have to be careful of what exactly is known, what exactly needs to be known for us to assess how it will behave. But I don't think we have to make another statement before we have a real evidence on things that are coming up. And as with the other 8 variants, we might end up with something that is not as dangerous as was felt at the beginning. Over to you, Kate.
Yeah, thanks so much, Purvis. So I think the ICP question has been addressed. So I'll just touch on Omicron and sort of SAGE's remit and that this very much moving target of how to optimize vaccine schedules for their performance. So when you asked about, well, what's the right time for a recommendation on what to do about vaccines and vaccine schedules on Omicron, the right time is when the data are sufficient to make a recommendation that countries can rely on and can act on. When you asked about population level data, I think really where our focus is going to be is on, of course, the neutralization data as an underpinning, but it's really the clinical data that are going to be most influential about how to manage an Omicron situation. And we're getting signals from these early neutralization studies about what the direction might be on that. But we certainly need more than what has come out at this point. So we're going to look at a combination of the laboratory neutralization data and the clinical data. Now, when you talk about timing of the clinical data, it may not take as long as some people might think it would take. We're not talking about clinical trials. What we're talking about is VE studies, certainly analyses that can be done on breakthrough infections, looking at the epidemiology of the infections that are occurring relative to vaccination status. So those are the kind of portfolio of studies that we know are underway and we'll be looking at in SAGE the entirety of the data. But I think we certainly would need some of the clinical data to move forward. That's really a decision by the SAGE committee that we will be putting in front of the SAGE committee all the evidence that accrues. And they are kept up to date on the evidence as it comes out. So it's also a decision by the working group about when there's enough information to put before SAGE. I also want to just address, SAGE has a global remit, has a global lens. It's a really different lens than one single country's lens about a policy decision. And SAGE has, for other antigens, provided recommendations about what to do in short supply, and that's really about prioritization. So I'll point to HPV as an example, where the availability of HPV vaccine has some constraints to it, and a recommendation from SAGE about the prioritization of girls as opposed to a gender neutral policy. So these are the kinds of things that SAGE looks at, is both a global lens on the supply perspective relative to where the best and greatest impact of a vaccine can have. So I think our advice and our review by SAGE of the data on boosters, again, I really want to keep emphasizing that we've looked at the whole spectrum of the impact of boosters on both infection, clinical disease, and the severe end of the disease spectrum. We're clear on what the evidence shows at this point. And I think we've been as clear as we can be at this point about the next step that SAGE will undertake to look at how this, where this layers into prioritization. And that prioritization is both on a country level and on a global level. So it is both lenses, because SAGE's role is, of course, to take the global perspective, but to provide advice to countries that countries can take into their own national decision-making on how best to prioritize vaccines and in what order to use doses that they have available to get the greatest impact. So that's where the focus is. And given that any country is continuing to focus on the severe end of the disease spectrum, that's where we have to pay most attention. For a number of countries, there are a lot of countries now, almost 100 or just over 100, that have deployed some element of a booster dose program, many with a prioritization scheme. And some of those countries are advancing further than that, clearly operating against a hypothesis that they're trying to get at reduction in transmission, especially as we go into Omicron, learning more about whether an additional dose is going to do anything to improve performance against that mild end of the disease spectrum, or the infection disease at the end of the disease spectrum, is where we'll be looking at data as well. But we're really focused, again, on that severe end of the disease spectrum and what can be done in every country to optimize that side. Thanks.
Thank you very much, Dr. O'Brien. The next question goes to Priti Patnaik of Geneva Health Files. Priti, please unmute yourself and ask your question. Priti, are you?
Yeah, hi. Just following up on what Kate O'Brien was just talking about. Thanks for laying out on what the SAGE recommendations mean globally. Just to sort of pursue on that line, this is more like a governance question. It seems that these are recommendations, but do not have a legal weight in that sense. And countries have a fair amount of latitude on what they do with advice from SAGE. In the context of these acute, crunch in supplies, it does become problematic if countries disregard SAGE advice. I just wanted to understand, how does SAGE advice actually get translated into policy and practice at the national levels? That would be helpful, especially in the context of boosters and Omicron and all of that. Thanks.
Thank you. I think this is a question for Joachim or Alejandro.
Yeah, I can take it. Yeah, so clearly SAGE, first of all, is an advisory group to the Director General. And on that basis, then the organization issues policies and recommendations. As you rightly point out, they do not carry legal weight. There's actually not that much, so to say, legally binding instruments that we have in international health. So I think this is a normal situation, and most of the products coming out of WHO are advisory. And there are 4 countries to consider in their own decision making. Now, in relation to immunization, we actually have, I think, to some extent, the privilege that many countries have dedicated advisory groups in countries, national immunization technical advisory groups, or NITAGs, as we say, that to some extent mirror what SAGE is doing, and to provide the advice to countries then in order to issue their own recommendations, or sometimes also certain legal requirements. We have a dedicated effort in order to have a crosstalk, first of all with our regions, where there is also advisory groups, but then in particular with countries and their national immunization advisory groups. And we have ways of interaction, webinars, other forms of interaction, where we communicate our recommendations to countries, where we have opportunities for exchange. We're also trying to solicit feedback actually from countries in terms of what on their side are the most pressing and burning questions, so that we probe and test the relevance of the work we are doing. So that is the way we are proceeding, but it's true and it's clear, it's advisory, that's within the mandate, that's the way the World Health Organization has been set up as an international organization, very few legal instruments.
Thank you very much, Joachim. The next question goes to Corinne Gretler from Bloomberg. Corinne, unmute yourself and ask your question.
Hello, thank you so much. Sorry if I missed these earlier, but I want to be sure I get this right. Your recommendation that ideally people use the same vaccine for the 2 primary doses, does that also apply to boosters? And then also, did you say whether healthcare workers are recommended to get a booster shot? Thank you.
So I think that one was for Kate.
So on the issue of what we call heterologous, so the mix and match, what we have come out with, what SAGE has come out with on the heterologous is both for the primary and the booster. We've made on the product specific, I think this has been described before, that for the inactivated vaccines, they can be followed from an inactivated either for the subsequent dose, the second dose, or if a third dose is being given with another product, either an mRNA product or a viral vector product. In terms of the preference for whether it is homologous, in other words, the same vaccine for 2 schedules, or for the 2 doses, or if a third dose is being given, is there a preference for it to be homologous, or is there a preference for it to be heterologous? We would take a pretty neutral stance on that. We want to really be sure that countries have flexibility. I want to point to the fact that most countries, on average, countries have 4 different vaccines in their programs. And this is unlike any other vaccine that we have. For every other vaccine, a country would select a product for which they contract, and then they would stick with that product and perhaps make a switch in the future. But the idea simultaneously having multiple products in a program is a really difficult programmatic practice, because of the until the evidence has come out about the ability to interchange these vaccines, you would then have to stock multiple vaccines and know exactly what vaccine somebody received as their first dose. So we're being relatively neutral on this, allowing for countries to have more flexibility according to the constraints that we've identified in the recommendations. From the perspective of sort of, we see the tried and true perspective of giving homologous schedules. So certainly there's much more data on using homologous schedules among the 8 billion doses given. Most of them are homologous schedules. And so that's where we have most confidence in the data, but we do want to provide that flexibility for countries to ease up some of the programmatic constraints and ease up the ability for people to, with the greatest of ease, get their second dose after they've received a first dose. We have not, I just want to be clear, we have not provided a recommendation for people to get booster doses. We've reviewed the evidence for the reduction in performance of vaccines over time. We've looked at that evidence carefully, and we've looked at the evidence for when you give a booster dose, what actually happens. So those are the two sides of the coin. And then of course, sorry to mix the metaphors here, but the third leg of the stool is the safety of giving a third dose, a booster dose. So that what SAGE has done is looked carefully and in deep and wide at all of this evidence, including the modeling data that helps us understand what the relative benefit would be of giving a third dose as a booster compared with using those same doses to extend the primary series into younger age groups, in other words, lower risk age groups. And what SAGE will do now is, having really gone up one side, down the other, in and out on these pieces of evidence, will now consider how to incorporate the idea of booster doses, the practice of booster doses, into prioritization. At what point would you do that? And especially at what point you would do it relative to the supply that is available. Thanks.
Thank you very much, Dr. O'Brien. The next question comes from Donato Mancini from the Financial Times. Donato, please unmute yourself and ask your question.
Hey everyone, hi. Thanks for the briefing. Thanks for taking my question. So I realize this may be premature, but are you eyeing any policy in terms of Omicron targeted shots if it turns out that we need them? And since we know that supply will be very tight, at least initially, and much tighter than it is now, actually, if we do need them, do you have any recommendations on how they should be deployed? Should we expect similar guidelines to the ones we've seen so far? What can you tell us? I know it's premature, so go ahead with the caveats if you need to.
Thank you. I just noted I missed something from Professor Craviotto. He wanted to mention something on the health worker question previously. So we'll start with Professor Craviotto, and if others want to come in on your specific questions as well, we will.
I just wanted to reinforce that in the case of the health workers, depends very much with what vaccines they have been immunized. If they have been immunized with the inactivated vaccines, then yes, they should be part of receiving as soon as possible a third dose of the vaccine. That is something that will worry us in that sense. In the case of many low-income countries, these health workers have been vaccinated with vaccines that have not received any UL by WHO, such as CanSino. And that vaccine also would require a second dose in that sense, since we feel that it is not enough with the protection afforded by the first dose. So in that sense, it would be a country decision, but they would fall into line with what we have been recommended for the other vaccines, even though these vaccines have not passed through the EUL and a SAGE recommendation. So in that sense, given the importance of protecting the health force, yes, we do believe that in those cases, they should be a priority group for receiving a third dose in that sense. And in the case of Donato's question, if I just chip in for the start of the discussion, I think we had the discussion about vaccine specifics for Delta, and they never came up because we didn't need them. So I would suggest that we restrict ourselves to the information coming up before we go into these speculations, which I don't think they really lead into anything useful, but I defer to Kate for the full answer. Thank you.
Yeah, just to add to those comments from Alejandro, again, I'll just, one last thing on the healthcare workers. They are part of the highest priority group in our existing roadmap. And so as we move forward with the considerations of optimizing the performance of vaccines over time, they would continue to be in that highest priority age group as we consider the specific policies on how to optimize. On the issue of Omicron variant vaccines, perhaps I didn't understand your question at the beginning, and I think now I understand you're asking about vaccines that are specifically designed around a variant. And I think what you're getting at is for the supply, which of course would be more constrained at the outset than in the future. There are really several considerations to be made. One is, would there be preference for use of those vaccines as primary doses, or would there be preference for use of those vaccines as subsequent doses, additional doses, booster doses? And of course, then geography comes into the mix as well. And I think recognizing that the vast majority of unvaccinated people are in the African continent, and looking at where Omicron is being transmitted and is circulating, where we have, now many countries, both within the continent, outside the continent. Those are all considerations that I think would be part of the assessment. But I think what really we're going to be looking at is the performance of all of the vaccines against a variant. And I do think it's premature to speculate about what the best use of the global supply would be for protection of people. Notwithstanding, we, at this point, there may be evidence that shows that in fact the vaccines are holding up quite well against Omicron, especially at the severe end of the disease spectrum, recognizing that that T-cell immunity has, a much broader remit, and especially is important at that severe end. So I think we should avoid speculating about exactly what the pathway would be and where the greatest impact and best use of vaccines, should they be needed, that are variant vaccines. Really just too early days. The vaccines we have right now may be performing really well, depending on how they're used. So let's wait and see what the data actually say. Thanks.
Thank you very much, Dr. O'Brien. We have Ashley Furlong from Politico. Ashley, can you unmute yourself and ask your question?
Thanks for taking my question. I'm following up on something that Dr. O'Brien said earlier. She spoke about the quality of doses being donated to countries and the short shelf life and the lack of foresight that countries receiving these doses had. I wanted to know who is responsible for providing that information. Is it the donating country, or should the manufacturers be giving that information more readily to COVAX?
That's over to you, Kate.
The information, so the source of the information comes from a combination. How should I explain this? When a country is donating doses, they are specifying which doses. So what manufacturer and what the actual supply is that is being received. So the information comes from the manufacturer because the donating country has specified what the doses are that are being donated. But it can come from the country as well. They have that information. So it's not that there's one source of the information. It comes from both the manufacturer and the donating country. What is important here is that it is within the control of donating countries. What we're really asking for is a greater sightline into the donations. So the decision to donate, the setting aside of doses, the planning with the manufacturer on either a monthly basis or a quarterly basis that a donating country would like to donate, X tens of millions of doses in this quarter and another, set in the next quarter. So it's really that sightline of what doses we're talking about, of what product, in what time frame. And then the whole planning system can happen in a much more organized way, so that countries that are in most need of these doses and have the programs that are trying to ramp as quickly as possible actually can plan for that, can plan the cold chain, can plan the demand generation, can plan the actual vaccination sites. And that's what's been in deficit right now, is we have very short notice that a country has decided that they will donate a specific product in a specific volume. And there have been, as you know, some earmarking of countries as well for those donations. So we're really asking for that sightline planning and as flexible a remit on the countries, so that the full allocation, not just of the donated doses, but also the purchased doses, can take place in a holistic way.
Thank you very much, Dr. O'Brien. We have one follow-up from Isabel Sacco, where way over the hour. I think we were only going to do 45 minutes, but we've had huge number of participants and questions. So look, Isabel, I'm going to actually give the last question to Latika Burke, because she hasn't had a question. You had a question. Latika Burke, Sydney Morning Herald. So Isabel, can you send your question as a written question? Because I think we're going to run out of time. So Latika, please unmute yourself and ask your question.
Thanks a lot, and thank you very much for the briefing, reiterating what everyone else has said. Dr. O'Brien, just on your comments earlier about the focus on the boosters cutting transmission in the countries that are doing it versus the need to mitigate serious disease and death at this point, I'm just wondering how you have this conversation with several countries. So, for example, Australia works very hard to eliminate the virus, and actually any sort of transmission is a very big deal for a country like that. In the UK, where I'm based, for example, they've also had a horrific time with COVID, and any sight now of that immunity waning, which you've said it does up to 6 months, is really troubling for people to look around and see people now getting sick from a virus that they've seen kill more than 100,000 people. So what is the message that you have for people living in those countries about why boosters are actually unethical for them to take?
I think that one's for you, Kate, again.
Yeah, thanks. I'm just waiting to be allowed to unmute. It takes a little moment on the technology to get the permission to unmute. So thanks for the question. Let me answer in a couple of ways. The first thing is that transmission reduction is not about vaccines only. There are, we all know, very clear, easy to follow, relatively easy to follow, that may be harder over time, methods to reduce transmission. What I think is a bit perplexing is that there is an inconsistency in some countries around the pursuit of the reduction in transmission. On the one hand, pursuing very, sort of a no holds barred approach to the vaccines, at the same time not using masks, hand washing, crowds, all of the other measures that we know are highly effective at reducing transmission. So part of this is about consistency of using all of the tools available. We've been saying it, and I'll say it again. This is not vaccines only. This is vaccines and. So if the intent of a country is to aggressively and actively pursue transmission reduction, it would be important to use all means necessary to do that, because the vaccines, even after their initial administration, as you know, are partially effective against transmission reduction and protection against infection. It's never going to be the vaccines alone that are going to end this. And given the increases in the R0 and the transmissibility, the idea that these vaccines, the vaccines we have now, are not performing at the level where the concept of herd immunity is likely to be something that can be achieved with the deployment of these vaccines, because of the transmissibility of the viruses, and through modeling, it's unlikely that that's going to be a big strategy, a big component of shutting down disease. So what is going to shut down disease is for everybody who is especially at risk of disease to become vaccinated. That's protecting them against that severe end of the disease spectrum. And we seem to be taking our eye off that ball in countries. That's where the disease still happens, is largely in unvaccinated people who are at risk of the severe end of the disease spectrum. But notwithstanding that, individual country goals and individual country pursuits are using and can use all of the tools at hand. What the problem has been is that there was inadequate supply, as you know, from a global perspective, that was available to actually get the highest risk groups protected against severe disease. And so while one country is pursuing a transmission reduction approach, there are healthcare workers who are literally dying on the job in other countries because there has not been access to vaccine. Now, in the past 6 weeks, the past 8 weeks, that picture has started to change. The doses are being donated. Doses are now flowing through COVAX. There are large numbers of shipments that are going into countries, and countries have been waiting. They have been waiting and waiting and waiting. It's going to come, it's going to come, it's going to come. And now it is starting to come, and we have to make sure that it continues. As we head into whatever the Omicron situation is going to be, there is risk that the global supply is again going to revert to high-income countries hoarding vaccine to protect, in a sense, in excess, their opportunity for vaccination and a sort of no regrets kind of approach. And what I think is just so important is it's not going to work. It's not going to work from an epidemiologic perspective, and it's not going to work from a transmission perspective unless we actually have vaccine going to all countries, because where transmission continues, that's where the variants are going to come from. So both of these things can coexist, but we have to have a much more rational global perspective from countries about what's actually going to shut down this pandemic. We have the tools at hand. We have the choices that we can make, and the next days and weeks are really going to determine sort of what direction the world decides it's going to go in on Omicron. This is really in our hands to decide this. We do need to reduce transmission further, but the approach on the vaccines, it's not vaccines only. It has to be all of the other measures as well. And I think we would really very much like to see a much more intentional approach to that across a large number of countries.
Thank you very much, Dr. O'Brien. And on that really strong and important and positive note, I will ask Professor Cravioto to close this meeting. Thank you all for participating, and we will answer any questions you didn't get to ask. We'll do our best to answer in writing via media inquiries. So over to you, Professor Cravioto.
Thank you very much for the honor. I think there's little to add after what Kate said. We just insist for people to get vaccinated. We must remind that the people who are dying are the unvaccinated. Second, to use all the other elements we have in hand, which the children have shown us how good they are, especially now that we have reopened our schools and allowing them to get educated. And third, that everybody in our working group, which is a large participation of real important people in the sense of their specialties and their knowledge, have been given for the last 2 years their time to be able to come up with these recommendations. And I think we should all be very thankful to them for the help that they have been giving us, for the time that they have been giving us, and for the way that people have taken so seriously the idea of looking at evidence and making recommendations for everybody's benefit and health. I think we owe them a huge vote of thanks, and to the people in WHO that lead the Secretariat, Joachim Hombach and his group, who allow us to have these meetings constantly and come up with these recommendations. Thank you, Margaret. Over to you.
Thank you very much, Professor Cravioto, and thank you to everybody who stayed. This has been one of our longest press conferences. You've all asked brilliant questions, and as always, we'll be here to help you. Say goodbye now.